Ladies and gentlemen, welcome to today's webinar hosted by the Supportive Care Coalition and the Catholic Health Association. Today's presentation is titled Palliative Care and COVID-19, Implications for Clinical Practice, Part 3, presented by physicians Olamuyiwa Adeboye and Greg Vandekeef, and bioethicists Nate Hibner and MC Sullivan. Before we get started, I'd like to mention that today's session is being recorded, and you are currently in a listen-only mode. You will be receiving an email tomorrow with access to the recording to listen to on demand. A large portion of today's webinar will be a question and answer period, so please use the questions panel on the right side of your screen to begin submitting questions at any time for our panelists to discuss. We also encourage you to share what you are doing to support healthcare staff during this stressful time, as well as links to resources that you have found helpful. We will share them after this session on the SEC website's COVID-19 resource page. If you experience any technical difficulties during today's webinar, you can click the Help tab at the top of your control panel or ask me a question directly in the questions panel. Now, without further delay, it is my pleasure to introduce your moderator for today, Denise Hess, the Executive Director of the Supportive Care Coalition.
Thank you, Brianne, and welcome everyone to today's webinar. As Brianne said, presented by the Catholic Health Association and the Supportive Care Coalition. For those of you learning about the Supportive Care Coalition for the first time, the coalition is a partnership of Catholic healthcare ministries from across the U.S. dedicated to advancing excellence in palliative care through ongoing advocacy efforts at the local and national levels, through interprofessional education, resources in healthcare ethics, and the integration of spirituality in palliative care practice. Coalition members have complimentary access to monthly webinars, numerous resources on our website, and a community of like-minded learners from all disciplines represented in palliative care. And as Brianne mentioned, we have also added COVID-19 resources to our website that you can see here for those of you joining us on a computer platform. And since caregiver well-being is very important to us, especially in times like these, we also want to highlight our caregiver well-being page, where you will find numerous short reflections, meditations, and readings designed to ease the way for all of the people taking care of patients and making difficult decisions during this pandemic. Today, we are especially excited to welcome back our 4 panelists to lead today's discussion. Dr. Olamuyiwa Adeboye is the Medical Director of Palliative Care at Ascension Health. Dr. Greg Vandekeef is the Medical Director of Southwest Washington Region of Palliative Care and the Associate Medical Director at the Providence Institute for Human Caring. Nate Hibner is the Director of Ethics at the Catholic Health Association, and MC Sullivan is the Chief Healthcare Ethicist and Director of the Initiative on Palliative Care and Advanced Care Planning at the Archdiocese of Boston. The plan for our hour together today is to have our panelists address several case examples that have come directly from palliative care teams working in the midst of the COVID-19 pandemic. Then we'll end the hour with a Q&A session from you all, where we will hear from you. Please, as Brianne said, share your questions, concerns, and experiences in the questions panel. We will get to as many as we can. And so as I prepare to hand it over to our panelists, I would like to begin by offering this prayer written by Sister Joan Chichester. Loving God, lead us beyond ourselves to care and protect, to nourish and shape, to challenge and energize both the life and the world you have given us. God of light, God of darkness, God of conscience, and God of courage, lead us through this time of spiritual confusion and public uncertainty. Lead us beyond fear, apathy, and defensiveness to new hope in you and to hearts full of faith. Give us the conscience it takes to comprehend what we're facing, to see what we're looking at, and to say what we see, so that others hearing us may also brave the pressure that comes with being out of public step. Give us the courage we need to confront those things that compromise our consciences or threaten our integrity. Give us, most of all, the courage to follow those before us who challenged wrong and changed it, whatever the cost to themselves. Amen. And so with that, I will queue up for you all the first case study example. And we will begin with having Doctors Vandekeef and Attaboy addressing the issue here. So as many of you know, today is National Healthcare Decisions Day. And while advanced care planning has never been more important, we are facing new challenges in facilitating advanced care planning conversations and obtaining signatures for PULSE due to the pandemic. We have patients in isolation who cannot sign documents or have in-person discussions with their designated decision maker or known witnesses. So the question is, how are other palliative care teams handling these issues? Also, we have a large outpatient palliative care census. Should we be advising our seriously ill patients to update their advanced care planning documents in case they become infected? So Greg and Muiwa, thank you for joining us today, and I'll let you start us off.
All right. Thank you, Denise. I guess I'm kicking off this one, Greg, right?
Yes.
There's two questions in here and with multiple layers in each one, but it is nice to acknowledge it is National Healthcare Decisions Day. What's more important after taxes, which have been deferred, right, or delayed tax filings, than death also, which follows your tax filing day. Bad joke. Anyway, this is an interesting question that I think has come up in a lot of places. Advanced care planning conversations typically are meant to be done in a regular, normal setting with ease and calm and things like that. But the COVID-19 situation, I think, has heightened the situation and has made more people aware of the fact that, we need to get our acts together. Now, one of the things I would say right off the bat is kind of know what your state laws are around this. I think each state is different. Here in Wisconsin, we do have a state document, but also practicing within the organization we're in, we also have our own document, which is a bit more elaborate than the state document. Each state is different in terms of what the criteria are. Some states require witnesses, some don't. Some states require that the witnesses not be medical staff. Some require that they not be family members. But I think knowing those details would be key. Also, in terms of where things are at, it's good to know right off the bat who has and who doesn't have a document. And one of the things I think our organization has done is created a policy where right from the emergency room, somebody now is identifying one, who has a document, and if they do have a document, who the decision maker is on that document, so that the name of that person is right on the front of the chart should any major decisions need to be made if the patient cannot make those decisions. If there's no document, there is guidance about how to proceed with that. And again, though it might not be the best case scenario, I think it's good to know what that is like. I know there's been situations of creativity around that. I've seen situations where someone has talked about video calls to kind of have that witnessed. I haven't really seen that happen, but I've heard. But I think it's one of the things that needs to be factored in. The other thing I think that we kind of addressed too was, and I think, Greg, maybe you're taking this on, the issue of whether the patient themselves have the capacity, medical decision-making capacity or not, and I'll hand that over to you.
Thank you, Muiwa. As we were talking about this yesterday, something that came up repeatedly is the point that was made earlier about knowing your state rules. I practice in a large health system. We're involved in 7 states in the Western United States, and this topic came up with palliative care medical directors and operations directors across the system. And what was striking is the variability in how institutions were responding to this question. But then that reminder about different state laws. For instance, we have a document in our EPIC build that's called the Trusted Decision Maker document. And for a person who, for whatever reason, is unable or unwilling to complete a durable power of attorney for healthcare or a more legal proxy document, they can still verbally designate and potentially even sign a document indicating who they want to function as a surrogate that falls short of official legal designation. In California, for instance, that actually carries more weight based on statute. And so knowing the surrogacy laws, the signature laws in your own state is going to be really critical. I also saw in the public media that New York Governor Andrew Cuomo had relaxed some of the requirements around notarization in New York and expanding the ability to do notarization by a virtual encounter as opposed to in person. That's only valid during the COVID pandemic. And meanwhile, during the conversation I referenced earlier, some of our other states were very clear that would not be okay in the state in which we practice. So again, knowing your state regulations around surrogacy laws and signatures and notarization requirements, but also recognizing what the variances are that have taken place during the pandemic, some of which may carry over after things relax, some of which will go away. So this is a moving target. We also mentioned the issue around decisional capacity. So if I think about this as a practicing clinician, I was going to say at the bedside, but now it might be out in the hallway or at the nurse's station since we're not always going to the bedside. But how do we do this with our patients? So again, for a patient that has decisional capacity, but is COVID positive or is a person under investigation, the question arises, can they handle the hard copy document, put a signature on it, or is that going to cause concerns about the possibility of transmitting the virus, of it being a vector? And so knowing not only the sort of legal and ethical elements of this, but the practical elements. What are your infection control teams saying about documents or anything in general? Are they allowing things like that to go into the room and be signed and be returned? Are they requiring a time interval between which you handle it? Things of that sort. I know in most institutions they're saying for a COVID positive patient or a person under investigation, we don't want to send something like that into the room and risk exposure to our staff. So then again, it gets tricky. Does your state allow a two-witness verification? Here I'm thinking of the parallel of when a patient lacks decisional capacity. A pulse form needs to be completed before they're transferred to their nursing facility. All of their surrogates are out of state. How do we accomplish that? Typically, we would have 2 clinicians witness the conversation over telephone, typically using a speakerphone. I've also done this on video conferences in the last few weeks. And then we actually fill out the patient signature section of the pulse stating that this was the choices that were made and it was witnessed by a virtual encounter, not an in-person encounter. And at least in Washington State where I practice, that would be valid for transfer to a nursing facility, for admission to the nursing facility. In a perfect world, you would want to try and eventually get back the document to a surrogate and get it signed. And so the final thing would be providers versus physicians. So Muyuan and I were talking about this yesterday, and in some states, they actually have requirements that prohibit nurse practitioners or physicians assistants doing some of what they can do in other states. So once again, recognizing which clinicians have which scope of practice in surrogacy designations. Lastly, before turning the baton over to Nate and MC, the second question, we have a large outpatient palliative care census. The short version to the answer of that question is yes.
Yes.
And you could probably even delete the phrase in case they become infected. This has changed things enough, and we're recognizing enough about how dynamic patients' advanced care planning wishes are, that certainly doing an update would be relevant. And Moyo, anything you would want to add before we pass the baton to Nate and MC?
I think there was also a question Denise had raised earlier on about, just in general, people were asking, if I already have a document, should I kind of change certain things in there? And I think it would be wise to kind of review what your document says. You might have made certain choices. There are different things in there. What are your wishes around nursing home placement? Is that the same? Has that changed? Knowing what's going on right now, what are your wishes around resuscitation? What are your wishes about end of life care, and so on and so forth? Certain documents have certain different nuances to them, and so it might be helpful, just kind of review your document now, see what still stays and still what needs to be updated, and of course, post-COVID, once things hopefully go back to normal, take a look again and see if those are things that you still would wish to have in place. I guess for some people, it wouldn't change. Nate and MC, we hand it over to you.
Thank you. So because I got on first, I'm going first, Nate. Sorry. But I was struck as I listened to both Muyiwa and Greg, I was struck by a couple of things. So the first thing that struck me is how fantastically broad and comprehensive they were with their answers, and how very practical in the suggestions that they made and in the considerations that they spoke to throughout this kind of case study of, as Muyiwa said, multiple layers in each question. But one of the things that the overarching thought, not just for our question, our case study here this morning, but for the whole experience of the last month here in the Boston area, is that in many ways, the nature of the illness and the isolation technique that is meant to happen in terms of, patients and clinicians not even seeing eye to eye, and I mean literally, many cases not being surrounded by their loved ones, and in many cases not by their healthcare proxy, and communication being difficult. It struck me that really we're back to where we were pre-PSDA, pre-Patient Self-Determination Act, pre a lot of the kind of consumer activism that infiltrated and permeated medicine to allow and encourage and require ultimately patient input. We're back to the days before that, because a lot of the niceties are just stripped away at this point. We might not have the documents. We might not have the healthcare proxies there or the family people there to have meetings and discuss this with the patient who may be competent, or in the absence of the patient's competence. So we're kind of back there. The difference being that we did have PSDA. We did have the court cases that have informed patient input. We have had the Last Acts project that RWJ funded and really brought about tremendous amounts of change since the kind of dire findings about advanced care planning in the support study that came out in the early 90s. And that's reflected in what we just heard from Greg and Muyiwa. So, the fact of the matter is we're back to where we're doing conversations. They might be over iPhones or iPads. They might be long distance and remote to the families who are no longer allowed to visit, and the healthcare proxies that are no longer allowed to visit. But the point is that we are looking desperately and in every way that we can, and using all the technological benefits of the 21st century to get patient input, patient guidance, patient preferences, patient values, and patients' decisions about what should happen next. And I find that tremendously heartening. I find that absolutely we're going to run into barriers and we'll experience frustrations, and yet at the end of the day, listening to our two clinicians and knowing that behind them are the tens of thousands of other caregivers, at the end of the day, people are trying to do the right thing, which is to get the guidance of the person most involved with the support of those who are their support network. I found that tremendously heartening. So with regard to the second question about, should we be notifying people in our palliative care practices to complete documents or to review, as Muyiwa said, what they've completed already, beyond a shadow of a doubt. When we first started looking to patients for their consent to treatments and their participation in decision making, a lot of what we talked about was the need never to put pressure on them, never to put undue pressure that would kind of direct them one way or another. Well, in this situation, the urgency of the circumstances are definitely that kind of pressure. And yet that's also the reality. So whether it's the patient who's showing up in the ER and you're trying to solicit and elicit what their expression of decision making is, what their concerns are, what their values are, et cetera, or whether it's people not yet infected or perhaps don't know that they are, but all of us have to assume it may come our way. Absolutely, we need to encourage them to complete the forms that they haven't and to review the forms that they have. Nate.
Well, I'm not sure what else I can add to the three of you who just cover the entire span of potential ethical issues as well as practical clinical application. But I wholeheartedly agree, MC, with what you're saying here. I think some key points would be, once again, we are seeing how modern or cutting edge or these new techniques that we've become reliant upon, when they have been removed, we have to fall back on our own personal formation, our own desire to do what's good for another person, to uphold the human dignity of the patient in their time of need. All comes back to how are we personally formed and how are we intending to do that in every action that we take. Concerning Greg and Muiwa's conversation around remote notaries, especially Greg's conversation about the different states, I want to highlight that the American Bar Association and the National Notary Association have websites for COVID response right now that highlight what state regulations have temporarily changed during this crisis to allow remote notarization, differences around the witness categories, as well as verbal declaration of a designated power of attorney for healthcare decisions. So I would recommend, and we'll have those links attached to this slide. You know, besides in that second question about should these people be re-examining, obviously we should all be re-examining. What I think that the pandemic is probably going to point out is that advanced care planning is not just for somebody who is older in life. It's not for somebody who is expecting some sort of crisis of healthcare in their own personal way because of comorbidities or chronic illnesses that they're experiencing. But right now we are seeing how this disease is affecting all age populations. And so now all age populations need to sit down and have a serious conversation with their loved ones, start writing out what their advanced care planning documents are asking them to fill out, start signing the forms in advance. So this should give a sense of urgency, not only to those who are in a chronic care state or who are in a nursing home, who are just older, but everyone needs to start, really having serious conversations about this. And this is that kind of opportunity. In our tradition, we often, in the Catholic tradition, we obviously have the ars moriendi around the art of dying, but more importantly, it's about, preparing ourselves to always enter into eternal life. And so this is just one of those ways where, because we are experiencing a time of pandemic and crisis, that perhaps that vision of the next life just seems to be more imminent, and therefore the urgency to perhaps prepare ourselves is being more motivated right now than it has in the past.
That's a terrific point. In all of this, as we're talking about logistics, both the clinical availability of services and what works best and what we thought we knew that we don't know and what we thought worked that isn't working and what the state laws say, we forget it is all about preparing people to enter the presence of God as well. And so, as we hear about spiritual care departments being furloughed because right now all eyes are on ICU space, or because frankly, many of those folks are in at-risk populations. Tremendous numbers of our spiritual care colleagues have been furloughed during this pandemic because they're in an at-risk population due to age or existing conditions. But one of the other things that I thought was particularly interesting is that Greg kept calling people to check the regulatory status and the legal status of what's available in their states, and they do vary tremendously state by state. One of the other things that I want to also call people's attention to is the fact that within their own hospitals, and this was definitely alluded to, so it's not as though it was not mentioned, but I want to get a bit more specific about the fact that there are existing protocols in virtually every hospital about what to do in the absence of a competent patient who can contribute to the discussion, and in the absence of documentation, or in the absence of family or particularly healthcare proxies. And that happens more often than we want to think. And yet, hospitals have dealt with this. So I call on clinicians, but I also call on ethics services to kind of make sure that they're putting out there as an available piece of literature, an available resource, the protocols surrounding that. You know, many people, many hospitals, many systems, and quite frankly, a lot of public health departments have addressed this and talked about best interest standard, talked about futility standards, et cetera. And all of those will be brought to bear in those situations where we don't have the ideal circumstances of having a competent patient, having documentation that's quite clear, or having the family and the proxy input. So, you know, we need not just to know that we have them, we need to make sure that the people who need them are up to speed. Many of those documents, I know this is true in the systems that I work with, many of those documents have been recently in the last couple of years revised based on a lot of case law for sure, but also on clinical practice. So I would just remind everybody to dust those protocols off and make them available.
Absolutely. All right, I think we'll go back to the clinicians and allow them to walk us through case number 2.
Perfect. Thank you, Nate. And as we navigate over to case number 2, I would just invite everyone, again, who's joining us via a computer platform to notice the chat box. As our speakers are referencing resources, we are sharing those for you live. So Drs. Attaboy and Vandekeest, let's talk about visitation restrictions.
Well, this question could have come from my hospital. It hit so close to home. We are struggling on many levels with our current visitation restrictions. Patients and families are distraught over what can appear to be inconsistent or changing rules about visitation. Staff are distressed because they are expected to enforce the visitation rules. This gets even more distressing when the patient is at the end of life. How are others handling this? I suspect if we opened the chat box up for wide conversation, we would learn that everybody's kind of doing this their own way. And one of the things that Muyiwa and I really talked about yesterday when we were preparing for this was kind of the organizational structure. So again, I practice in a fairly large health system, and at the system level, we were hearing from many individuals raising questions almost verbatim to the way it's articulated on the slide in case study number 2. One family would not be able to have a visitor at all. The family in a room down the hall actually had 2 visitors in, and how is that fair? And who's making the decisions when exceptions happen? So as we solicited visitation policies in the setting of the pandemic, we did find that indeed the management is typically at the institution level. In many institutions under the chief nursing officer primarily, but also the infection control department, chief of medical staff, and others would have a major say, or chief medical officer. But then we were noticing that some places would not address labor and delivery whatsoever. Others would address places like labor and delivery specifically, or perioperative. Where it gets interesting is I just saw on one of the televised shows yesterday that there was a hospital in New York that did universal screening of all women that came into labor and delivery, and about 14% screened positive for COVID, of which the vast majority were asymptomatic. And you think about the potential spread to staff in the labor unit. And so even there, being mindful that we need to be protective is really critical. So what we ended up doing is developing system-wide guidelines, not a policy, but something that we could distribute system-wide to say, here are the recommendations for your institutions. And some of that is operational. Have an identified person who has the primary responsibility for your visitation policy, whether it's the chief nursing officer or a different individual. Think about who are the other key players, the infection control department and folks of that nature, housekeeping, security, and make sure that you're all on the same page and have a communication plan in place, because I've also seen that the visitation policies have evolved over time. So I went about a week in between clinical shifts during this experience, and the visitation policy when I returned was quite different than it had been when I'd been on most recently. So I've learned during the pandemic, each time that I'm on clinically, to ask at the beginning of the day any updates to our visitation policy. Not that I have any authority over who gets to come in and who doesn't, but I spend a lot of time communicating with family members or with patients, and they're going to have questions. Can my daughter come in and see me? Mom's on comfort care, but she's not COVID positive. Can I still come in and see her? And then the last thing I'll offer up that I thought was a really interesting twist was one of our medical directors reported having had multiple families in her region that had by telephone said, I'd like to convert my loved one to comfort care, because that would relax policy, because now that the person's at the end of life, I can come in and visit. But then once they got to the hospital, they said, we're not really that interested in comfort care after all. And they weren't sure if they'd been played, or if the family was simply seeing something new now that they were in person, or whether the family is just, as a matter of love and a desire to be there with their loved one, doing anything possible they could as a workaround to get there. And so with all of that, the final thing I'll add before passing the baton over to Muyiwa is, one of the other things we heard from a review from a legal person was, you say policy might be different at end of life. How are you defining that? Is that a matter of hours or days prognosis? You need to have some consistency if you're aiming for things being equitable. So have clarity so that from one chief nurse, or house supervisor to another, they know how to apply the policy consistently over time. Muyiwa.
All right. Thank you, Greg. I'm not sure how many people, I know Denise just put that in the chat box there. There was an article in the New England Journal of Medicine. It was a perspective article by, I think, what looks like a surgical resident it was titled Not Dying Alone, Modern Compassionate Care in the COVID-19 Pandemic, kind of highlighting, unfortunately, the situation with how we find patients dying alone in the hospital and the need for some compassion and make some recommendations. Takes me back to just last week. I was involved in the care of two separate patients. There was a lady who was non-English speaking and was not doing well in the hospital. She was initially a person under investigation. She came with cough and shortness of breath, and unfortunately didn't do well during the hospital course, and had a family meeting with the patient's family via Google Hangout. And everybody was there. There was one daughter at her bedside visiting. So the visitation policy for PUIs with the restriction was, I think, one family member at a time. So once we made a decision about going to a comfort-oriented approach to care, it turned out that one of the daughters lives about 2 hours away and herself had been exposed and was on her last day of isolation. So she wanted to come down and see mom because she hadn't seen her mom because she'd been in isolation now for almost 2 weeks. And so the question was, how do we facilitate that? I'm bringing this up and I'll get back to that. There was also another case of a gentleman who, this was not COVID related. Unfortunately, new diagnosis of terminal cancer, wasn't doing well, had been in the hospital for a few days, was not COVID positive. His fiance couldn't get to visit him. He was no longer decisional, and we had a conversation with his fiance about how to proceed with care. She opted, as she was his surrogate decision maker, she opted to have his care also transition to comfort-oriented approach. In both of these scenarios, communication was key. Number one, communication with family members in terms of what the expectation around visitation would look like. Number one, be ready to be screened. Number two, entrances to the hospital that you're used to are not the same anymore. You have to come in through a particular entrance now, and these are the things that you'll get. Number three, we're now on universal masking. Don't be scared if you see everybody wearing face masks. Number four, be ready to be asked, are you coughing? Do you have shortness of breath or fever, or maybe even be examined or whatever, depending on what the situation is. Now, so that was communication to set expectation for the family members who are going to be coming in. Then there was a communication within the team as well, because this takes teamwork, like Greg referred to. You want to make sure that if your patient is COVID positive, visitation does not expose people unnecessarily, or if you have family members who, like the person I described, are COVID, have been exposed and we don't know what their COVID status is, they are not bringing something into the hospital. So there's a need to have that communication. Now, with end of life care, our organization thankfully has a policy around that. And it basically references the CDC guidelines. And I was trying to find that just now and I couldn't find it, but I know the CDC has some guidance around that. So you figure out what your visitation is for a patient who's not COVID positive or not in isolation, for a patient who is in isolation, or special circumstances for the patient who has a family member who is COVID positive and things like that. So there's going to be a need for all that communication and figuring what the best case scenario is. The guidance is, will there be a need for PPE? How many people are going to be in at the same time? For us, it's one person at a time. And so setting that expectation and making sure that everyone gets that. If everybody's going to be coming in, it's going to be probably like round robin, take your turns and things like that. For the first case scenario, due to teamwork with everybody, the family actually wanted to take their mother home, irrespective of what was going to be happening. And we were able to make it happen. And the other gentleman, unfortunately, died in the hospital with family or with his fiance at his bedside. So, you know, each case is going to be different, but I think the key point is there's going to be a need for communication within the team, because it's going to take teamwork to make sure it happens. Know what your policy says, and then set expectations with family members. That's it on my end.
I'll just add two things real quickly before Nate and MC weigh in on this. One of which is the impact on the staff caring for patients and the concept of secondary trauma. That is, we've really, in recent years, as the field of palliative care has grown, tried to humanize the clinical experience much more. And a lot of the requirements around visitation policies actually create separateness. It's a lot harder to have people physically present with the people they love during a time of trauma. And the way in which we're present is quite different. We're wearing personal protective equipment, and so our faces aren't as visible. And you see practical workarounds, people laminating photographs of themselves and putting them on the front of their gowns so the patient has an idea of who's underneath all those layers of PPE. And then finally, just people being alone at the end of life and what that does to the staff at the bedside who sees the suffering, the isolation, who hears the family on the telephone who's distraught that they can't be there. And so that concept of secondary trauma, where we are bearing witness to the suffering of others, particularly suffering that seems like it's quote unquote unnecessary, even if we recognize the need for isolation and physical distancing, it does seem elective in a way, and that carries a deeper weight. And so being mindful to support our staff. Here, I would give a call out to our chaplain colleagues who have done just absolutely amazing work. Many centers, they're 24/7 supporting families, supporting staff, and they're learning the art of communicating with their faces covered. One of our chaplains in Seattle was featured in a media piece where her face is covered with a mask, and the caption under her photograph said, "I'm smiling under my mask, can you tell?" And having to learn, whether you're using the Zoom platform, whether you're standing in the doorway, how to be present at an emotional and spiritual level, even when your physical presence is radically changed from what we're accustomed to. There is an art to that I think is really crucial. And with that, I'll wrap. And Moya, anything you wanted to add before Nate and MC take over?
Nope.
All right. And since
all.
MC went first last time, I'll call on Nate next.
Well, thank you both very much. Just to kind of go quickly so we can get to the third case, some points that you raised that are incredibly important. Systems need to be really thinking about what is your policy around this so that there's consistency. I think people are going to have a lot of distress, as the case example where they were told they could not visit their loved one, and yet down the hall somebody was able to visit their loved one. So how do we provide clear communication, consistency, not only to be respectful to the patients, but to their families, as well as to make sure that the staff are aware of what the policy is today or next week. Obviously, this is very dependent upon what kind of PPE you have, what type of situation your particular facility is in at that moment, what kind of patient load you're currently bearing, and how many people are perhaps facing end of life in a critical way. In an ethics standpoint, obviously, again, we're having a dilemma around conflicting values. How do we protect the population? How do we protect our staff? How do we provide people comfort at the end of life? How do we give people that compassionate care that we try to strive for every day within our own ministries? I think what is undergirding and underlying a lot of this, especially this case study, and the question that people might have is the fear that they will either be alone or that their loved one will be alone should they enter the hospital. And we have to be very, clear and communicate early on what is the expectations, what is the policies and procedures we're going to have in place, and how to alleviate some of that fear. Because what my worry would then be is that if people begin to be afraid in a very real sense that I'm going to go into this hospital and I'm going to be isolated from my entire family and I'm going to die alone, they're going to refuse to go to the hospital. Instead, they'll try to just stay at home as much as they can. So we have to be able to be very thoughtful about it, discern through it, communicate clearly about it, and recognize that that is an underlying emotion that is happening, and how do we address that in the way that we move forward. MC.
Thanks, Nate. As you alluded to, this is a case of not just conflicting values, but it's a case of conflicting claims on our duty. We're all about, particularly in palliative care, we're all about kind of bringing together this cohesive unit of family and patient. We're all about including the staff, or when it's staff and patient, including the family. And suddenly, as both Muyiwa and Greg pointed out, so practically and realistically, that's kind of blown to smithereens. There's not a lot. Frankly, there's not a lot to resolve that conflict, and that's where the tension is, isn't it? We live in tension of trying to figure out how to negotiate the unnegotiable. And so I've been really happy listening to, and as Greg pointed out, it's mostly coming from spiritual care colleagues of ours. I've been really happy hearing about the clever ways in which they've worked. Absolutely, the phone on the pillow or near the patient, great. Even better when it's an iPhone and FaceTiming can happen, or an iPad, or I frankly don't know the other platforms. I don't know what Samsung and the Android world does, but we know what the Apple world does. But more than that, and this has been really interesting to me. I was speaking with the head of the spiritual care department at really one of our busiest metro hospitals in Boston that has been slammed for almost a month now, almost at full occupancy, et cetera. And honestly, speaking to this head of the spiritual care department, you would think it was a day at the beach. And I asked her, why she was so relaxed. relaxed about all of this. And she said that they have set up in rotation 2 or 3 chaplains whose only job is to do telechaplaincy. And it's not the phone in the room or the iPad in the room. It's just dealing with the family members. That lifts the burden of the staff having to deal with the family members, not because they don't want to, but because what they have to kind of regulate around the patient room and patient care, it's all about no. And so this is a case of accentuate the positive, right? And so really the spiritual care department in this particular hospital has really led the charge, I would say, in our city, because they've shared with their colleagues across the city this idea that from the moment of admission at the ER or wherever, out in the parking lot where some of the admission and intake now happens, they meet with families and they really say what can happen, all the while threading into it what can't happen, because what can't happen, as we all know, are the usual expectations. And then they just make this commitment to stay in touch with the family, be the liaison, taking that off the staff as well, because of course they're following their patients. And so they report on those patients to the family, and they make themselves available very, very often. I don't want to say round the clock, but certainly if the occasion demands it. These are really interesting and unusual roles for both the chaplaincy folks, although it's not. It's just that usually they're doing it in person. So they're quite comfortable and quite good at it. And, I commend them for it. And I think more of us probably should be doing it. More of our systems should be doing it to the extent that it's possible to do it. And that's it.
Yeah, a lot of creativity out there right now, learning from one another, but especially in that example, the different people to whom we have some sort of responsibility or duty to, the patient, the family, and the staff. How can we meet the needs of all of those?
Even those.
Okay, so let's.
Yeah, even
sorry,
I was just gonna say, even those among us who like to pick a fight because play devil's advocate and all that, nobody can live comfortably or in a sustained fashion in a conflict situation and continue to function. And what these techniques do is just de-escalate that. It doesn't make it better, frankly. It doesn't make it anything that people would ever prefer or are even happy with. They're just not as off kilter and as upset, and frankly, in many cases, as angry. And that's a big gain. Okay.
Absolutely. All right, back to the physicians for case 3.
And we wanted to swing up and end on maybe envisioning what life after. I put it, going back to normal, of course, is in quotes in this, because there are many of us who are not sure things will go back. What will normal be after the pandemic? But if it's not too soon, can we ask you all to lean into what might be some of the lessons learned?
Well, I'll go ahead and start on this question, Denise, or this case. And I think the most obvious example of something that we all expect to see different in the post-COVID world will be our use of virtual encounters. Clearly, a lot of what has previously required in-person contact is being done telephonically and via video platforms. And some of that, like for instance, I don't think my dentist can do a lot of the work he needs to do, not that I need that much work, without my being there in person. But for many primary care things and many palliative care things, it can be accomplished more effectively than I think many of us would have anticipated. The family meetings I've had on the Zoom platform, I've often left at the end feeling the final outcome in many ways wasn't all that different than if we'd been in person. There's a difference in the dynamic in the moment. You don't relate quite the same way, especially if you've never met in person in the past. It's a little different for something like this. I know all of the other panelists from personal relationships, so I feel like I relate to them differently in a video encounter than I might if they were strangers I was meeting for the first time. And then even over the telephone, I've been just at times blown away by how deep our telephone conversations have gone around advanced care planning discussions and addressing palliative care needs. And so I expect that we'll see some of that carry forward in ways that it hasn't previously. And then the final aspect of the virtual interactions are meetings. The Supportive Care Coalition was supposed to be in Boston yesterday and today for an in-person meeting. We spent 4 or so hours yesterday in a Zoom-based meeting, actually GoToMeeting, excuse me, I have to make sure I get my platforms right. But I suspect many of those meetings in the future, people are going to say, what is the value of flying people from all over the country to a city, of paying for hotel rooms, getting variable quality hotel food, when we may be able to accomplish everything we need to accomplish virtually? And I think businesses in general, including healthcare, are going to be step back and revisiting some of these things more in the future. Muyiwa, I'll pass to you at this point.
All right. I think you hit it on the head with lessons learned. Virtual care is here to stay. I think I'll go back to, and I'm sure most people have seen the New York Times article about that was published on the 6th of April. It says, where have all the heart attacks gone? Kind of just highlighting what's going on with probably most people's ERs or hospitals pre-surge is your usual cases, the heart attacks, the strokes, the appendectomies. People are not coming to the hospital anymore, and how that is apparently impacting care. Are people staying home and dying at home? Do we know? Or are people just not coming because they don't want to be exposed? There's multiple layers to all of this. But I think one of the things that definitely might change is, how we communicate with patients, not only the modality, but spending quality time, because I think a lot of us are finding that, having that time now is important. I think a number of organizations are already starting to think of life post COVID-19. The question came up in a panel, in a webinar I was on last week, especially on the surgical side. All the patients who've had their surgeries, their elective surgeries postponed. How do you now bring that back in? Not even the surgical side, ambulatory care, outpatient clinics, people's annual physicals have been, pushed forward just to limit their risk of exposure. How do you start bringing all that back? And then, of course, to the community as a whole, again, highlighting this whole issue of delayed care in the setting of COVID-19, once things do go back to normal, is how do we continue to engage people to come back to the hospital and still keep a lot of all the semblance of hand washing and all these other things. It's going to be an interesting situation, but I think we're learning a lot that I hope will stay with us. Even on the palliative care side now, I think there are a lot of our colleagues who are now learning a lot much more about what we're doing, and especially in terms of picking up communication skills around this time, that I'm hoping will stay with them. So let MC and Nate go on, unless Greg has anything to add.
No, pass to MC and Nate.
Thanks. So this is really interesting. You've kind of touched on a really interesting ethical question as we emerge from the tightly held isolation and stay-at-home orders that we're seeing, and particularly, obviously, for purposes of our discussion here, I'll focus this question on healthcare. So, Muyiwa, you started talking about what's going to happen when we start to loosen things up. What lessons have we learned? I think we've learned a lot, and I'll speak to that in just a second. But I find myself thinking about the logjam of normal care that has been suspended, everything from elective surgeries to not so elective surgeries, everything from certain kinds of cancer treatments and certain kinds of cancer surgeries. Oh, it might just be a skin cancer, but if it was important enough to operate, why are we not doing the surgery? Yet it's elective. I get it. But when we start to open the doors and there is this logjam of people who have been waiting for care for some indefinite period and somewhat anxious about it, how do we prioritize that? there's a justice question here, and we need to be thoughtful about it. It will vary in terms of the standards for prioritization based on where people are located and what the resources are, but be sure to recognize that this is a justice question, and how do we do that? With regard to lessons learned, I think the practical ones that have been highlighted, just the way in which we have learned to socially distance. Who really wants to go back into a crowd with 50,000 people at a stadium, or with a couple of hundred people in a dormitory, or with dozens of people in a classroom? The implications going forward are going to be huge for the foreseeable future. And I know that in the news we're hearing about all of that. But what are the lessons that we've learned? I think we've learned a lot, and we'll be showing them as we kind of go back out into public, but maintain a social distance and not be in anybody's face. The other lesson that we've learned, and I say that we've learned it, but we've learned it generationally. So social media has been a place where older people like myself kind of wring our hands thinking, my God, people are so indiscreet, and they are so kind of without barriers or without any kind of sense of, this maybe isn't for sharing with everybody. And so they've been out there. Well, I've learned very, very nicely, I think, and happily, that in fact, there's a lot to this virtual communicating. There really is a lowered sense of barrier and resistance, and people are more forthcoming. I've found that that in the meetings that we've had, when we see the amount of telehealth and telemental health that has been really taken advantage of during this period, folks do relate differently when there is not just arm's length or 6 feet length, but when there's a screen there. And I think that, there's a tremendous upside to the idea of more perhaps focused and more sometimes appropriate and sometimes much more nuanced conversation that goes on, and interchange and exchange that happens than we might have been used to when you're kind of shy sitting, a few feet away from your doctor or your nurse practitioner or whomever. Nate, I think you're on mute.
Lessons learned are going to be in the hundreds. I mean, we're going to have so many. Every day we get a new question. It's like, oh, I haven't thought about that. Oh, that's something very unique. And that highlights a couple things. One is when we look back at those questions, and the ones that we answered, we're going to have to see, okay, did we answer it correctly? Did it have the impact that we wanted? What were the consequences, what we had hoped for? The ones that we were unable to answer, we'll have to figure out, okay, why were we unable to answer them? But the fact that we get so many unique questions every day, every hour, and sometimes, is again to highlight how it's impossible for us to be able to predict exactly what's going to happen in this type of crisis, correct? I think that's one of the biggest things we're learning, is that we predicted something a week ago and it didn't quite come out the same way today. We predicted something a month ago, and again, it has changed. And so I'm going to go back to my very first comment 3 weeks ago, 4 weeks ago, I forget how long we've been doing this, about the need to just go back to good moral and ethical formation of people, because what we need are prudential wisdom. We need people who are able to be in that moment, as you described the tension, who are going to be able to answer those specific questions as they arise, who might not be able to predict them into the future or might not be able to prevent them at all times, but who feels comfortable in that moment to take in all the facts, all the circumstances, and from their formed conscience as well as just their good character and virtues, are going to be able to give us what we need at that moment. Ethics is all very much people focused. It's what are my actions doing? Who do I want to be? How do my actions impact me and others? And unless we get back to that understanding of the fundamentals of good formation of people, you can have as many policies and procedures as you want. We're seeing that we're not always able to answer all the questions to a really well-written policy. And so I think that is a major lesson that I've learned, that I'm trying to continue to instill in other people. Your comments about personal relationships get right back at that. It's about how do we respond to others who are in need, how do we show compassionate care? How do we show mercy at this time? And so how do we prepare ourselves and prepare our coworkers and prepare patients and their families going forward so that those people are better able to handle a crisis when it might reoccur?
Brought us right into the closing time, Nate. Perfect.
Yes,
well,
thank you, Nate. That was that was an excellent note to close on. So important to remind us of that. And as we can all see, we are at the top of the hour. And thank you to many, many of you who submitted questions. I have some good news and bad news. The bad news, of course, is that we won't have time to get to them today. The good news is that we have several other educational opportunities coming up that we would like you to attend, because those questions will be addressed. So many of you were noting, as our panelists were discussing, the new practice behaviors that chaplains and social workers are engaging in now in order to provide compassionate care during the COVID pandemic. So to that end, next Thursday, same time, and for 90 minutes, because we're learning that we have lots and lots of questions from you all to address, we will be hearing from this expert panel representing social work and chaplaincy care. Then, in the weeks following, if you want to advance to the next slide, Rachel, we have 2 partner opportunities coming up. So there were many questions about, okay, advanced care planning, we know it's important, but we need more skills. How do we do that? How do we do it well? So our partners at Providence, here in Oregon, at the Institute for Human Caring, and faculty trained by Vital Talk curriculum, will be offering complimentary 1-hour virtual trainings in expert communication skills for frontline clinicians. These will happen on Wednesdays and Thursdays. They will be focused on specific clinical disciplines. So the one that's happening on April 21st will be directed at non-palliative care clinicians, so you don't have to be a specialist, who are working in an outpatient setting and want to learn some primary palliative care communication skills. Similarly, April 29th will be focused on people working in acute care and want to learn some communication skills in primary palliative care. Then secondly, on the right-hand side of your screen, you can see that our partners at the Catholic Health Association, along with Georgetown University, are going to be offering what looks to be an amazing series, following much of what Dan Somasi talked about with us last week, these very challenging bioethical issues that seem to be coming to the fore right now. And so each of these short sessions will, again, be complimentary, available to all, and will address a specific moral dilemma, clinical dilemma, ethical dilemma. So we invite you to register for both of those events. And again, thank you everyone who joined us today. We do encourage you to take a few moments to complete the program evaluation that will come up on your screen as soon as the webinar ends. We value your feedback and we use it to plan future webinars. And our panel, as Nate referenced, has been with us. This is part 3 for them. Thank you so very much, MC, Nate, Greg, and Muiwa, for sharing the information and expertise and really representing that voice of compassionate care that we hope to push to the fore during this time in Catholic healthcare and beyond. So again, thank you for being with us. Thank you for all of those listening today, and we do hope to see you again next week.
Thank you, Denise.
Thank you, Denise.